Hello, everyone. I'm going to wait a few more minutes to let a few more people arrive. Welcome to the Fertility Focus webinar on Polycystic Ovary Syndrome, Implications for Fertility and Pregnancy. I hope everyone has had a nice evening and is staying safe during the COVID pandemic. Okay, we're going to get started. Today, I just wanted to share I have no disclosures or conflicts of interest. If you could input your questions into the Q&A tool, that would be wonderful. It's a little harder to access the chat area. If I don't get to your question during the talk, I am happy to answer questions in the chat or the Q&A at the end of the talk. For right now, all the participants are muted. And if you'd like to share something, please use the Q&A. I'd like to start with a brief introduction on what is PCOS. PCOS stands for Polycystic Ovarian Syndrome. It's a clinical constellation of symptoms including irregular or absent periods, androgen excess, and we'll talk a little bit more about what that means. Androgen excess can manifest with symptoms such as acne and excess facial or body hair, or male pattern balding. Additionally, on ultrasound, the ovaries can have a polycystic ovarian appearance or morphology. Polycystic ovary syndrome is an abnormality in the signaling that happens between the hypothalamus and the pituitary, which exist in the brain, and how the communication with hormones such as luteinizing hormone, LH, and follicle stimulating hormone, FSH, communicate with the ovaries and facilitate ovulation with an LH surge mid-cycle. There are issues where ovulation doesn't happen as expected, and those issues can be anywhere in the reproductive axis, as shown here in this image, that incorporates the signaling feedback loops at the brain, including the pituitary, the ovaries, and the hormones secreted by the ovaries include estrogen and progesterone, which will be very important as we talk about implications on fertility and long-term health. How many people have PCOS? That's a really important question. Early studies indicated that approximately 6.5 to 8% of certain populations had issues with ovulation defined by those three criteria I just mentioned. Recent studies have shown that the prevalence can be as high as 20%. And this map demonstrates where some of those studies have come from as you think about how those studies can pertain to you and your lived experience. In terms of irregular periods, typically it's thought that fewer than 8 periods per year that are ovulatory are one of the criteria for irregular or more rare periods. Some women don't have any periods, and that's called amenorrhea. Shown here are some ways you can track your period, including a paper calendar. I used to hand these out very regularly in clinic when I was in training as an intern and resident. Now we've moved to tracking cycles using a variety of different apps. Some people track on their calendars. If you're concerned about your periods and whether they're irregular or not, a first step would be to track the periods. Your doctor will likely ask, when was your last period? And having a calendar in any form, even as simple as a piece of paper, can help track that to understand when there might have been anovulatory periods or irregular bleeding. Another major issue within women who suffer from PCOS include androgen excess. Some clinical symptoms of androgen excess, which means an excess of male type hormones in the body, include acne, hirsutism, which means excess facial and body hair, and hair loss, male pattern balding. Shown in these images are examples of extrafacial and body hair. Here of the upper lip, which is a common area. Other common areas include the sides of the face, chin, upper chest, in the abdomen area, around the nipples, as well as increased terminal hairs all over the body. Of importance to share with your doctor are factors such as hair loss, if you think you suffer from hair loss, which can be expected in certain time windows, but please do bring that up during your visit. Shown here are some examples of normal hair to a more severe grade 3 form of male pattern balding or androgenic alopecia. A final criteria is ultrasound evidence of polycystic ovarian appearance. This appearance has also been denoted as a string or pearls appearance. The image you see here is a transvaginal ultrasound image of an ovary, and that it's a cross-section, so it's a two-dimensional image, and the ovary is demarcated by a lot of round circles, kind of black circles, and those are fluid-filled cysts or follicles. And it's a typical appearance among women with PCOS where the recruited eggs in any given menstrual cycle arrest or stop developing at a certain early stage called the antral stage. And hence we see a large number of these antral follicles arrested, and that's called a polycystic ovarian morphology. It doesn't have to be, it doesn't have to look like a string of pearls. There can be multiple different visualizations of this, and there are different guidelines and cutoffs of how many cysts are required to have an ultimate diagnosis, and we'll talk about that in just a moment. I think having a morphologic appearance is important, but also can be seen in women with healthy ovarian function and reserve. This is a busy slide that's a summary of different groups and their characterization or definition of polycystic ovary syndrome. And summarized here are the definitions set forth by the National Institutes of Health, the Rotterdam criteria, and criteria set forth by the Androgen Excess PCOS Society. There are variations of the diagnostic criteria, and the most inclusive criteria are the Rotterdam criteria, which require any 2 out of those 3 findings of irregular periods, androgen excess, and polycystic ovarian morphology. It's really important to note that polycystic ovary syndrome is a diagnosis of exclusion after an assessment of the entire reproductive endocrine system, as well as other major hormones involved in reproductive functions, such as thyroid hormone, thyroid stimulating hormone, and prolactin. The main topic of today's webinar is to discuss health impacts on fertility and future health. PCOS affects multiple organ systems, and the image here describes how many organ systems could be involved. And of course, your doctor will know more about your individual history and will be able to explain what organ systems might be involved or at risk for you. But in a comprehensive way, adipose tissue or fat tissue function can be altered. Pancreatic function, including Glucose balance can also be altered in polycystic ovary syndrome. As we mentioned, ovulation in and of itself is very difficult and doesn't always happen in a typical 28-day cycle, or the range including up to 35-day cycles. There's an increased level of circulating androgens, and that sometimes that's detected on lab assay, particularly when there is an absence of symptoms that you might see. If there's no acne, excess facial or body hair, or alopecia, there may be signs in the blood. We'll talk a little bit now about long-term health impacts and wrap up regarding pregnancy implications. Because polycystic ovary syndrome leads to irregular, absent, or very infrequent periods, one of the concerns is the body is exposed to estrogen. Typically, in women who are cycling regularly, the menstrual cycle produces progesterone after ovulation, and this facilitates a maturation of the endometrial lining in preparation for pregnancy. However, if pregnancy doesn't occur, that menstrual lining is sloughed off. This is required to maintain a healthy balance of that endometrial lining. In women with fewer than 4 ovulatory or progesterone-balanced menstrual cycles per year, the risk of endometrial hyperplasia or overgrowth increases, particularly if that number of rare periods has happened for at least 4 or more years. While it takes many years of few or rare periods to be at risk, I encourage you to track to know if you might be at risk for that. Fertility is, of course, a major concern, and when patients come into my clinic, we have this very discussion. Impacts of polycystic ovary syndrome on uterine health, fertility, and future health. In terms of fertility, fertility is optimized when a woman is able to ovulate regularly, and the number of chances a woman has to conceive are proportional to how many times a year that woman ovulates. So it shouldn't be a surprise to know that ovulatory infertility is very common in women with PCOS. Sometimes lifestyle factors such as increased moderate to mild exercise, in addition to mild weight loss, even as little as 5 pounds, and dietary alterations can boost the body's ability to reset and cycle naturally. For women where that intervention doesn't work or is very challenging to undertake, there are multiple other options. There's a lot of help to facilitate and support ovulation. Sometimes that's in the form of medications. Currently, a leading medication is called letrozole. Other medications include one called clomiphene citrate, and both of these are pills, and they are used to support ovulation and are called ovulation induction agents. There are more invasive procedures, including ovarian drilling, which has been used historically, is less in practice now, but has been shown to be effective, particularly for the first 6 to 12 months after drilling, to facilitate regular cycling for the menstrual cycle. Finally, IVF, in vitro fertilization, is a very powerful tool to facilitate and support pregnancy. And all of these therapies are not without risk. Of note, women with polycystic ovary syndrome tend to have a lot of follicles or eggs, as I showed you in that picture earlier, that are arrested, waiting to be recruited during an IVF cycle. And that can put women at risk for something called ovarian hyperstimulation syndrome. If you are going down the path of in vitro fertilization, I'm sure your physicians will be talking to you about ovarian hyperstimulation and methods to reduce that risk. Something that's very important to me is the identification and reduction of long-term health risks in this table in the category of future health. Not everyone with polycystic ovary syndrome is fated to have future health problems. I mentioned before, health optimization is one way to reduce the risk of ovulatory infertility. Health optimization is also a way to reduce future health risks associated with PCOS, which can be extremely challenging. Even in attempting health optimization, sometimes we need to involve the support of nutritionists, physical therapists, as well as counselors. So some of those future health risks include cardiometabolic risks such as obesity, obesity-related insulin resistance, and type 2 diabetes. If in the constellation of hypertension, diabetes, and abdominal obesity, this is called metabolic syndrome. Obviously, during pregnancy, we must gain a certain amount of weight to support a healthy pregnancy. Women with PCOS can have additional challenges in losing the weight postpartum, and it is very important to understand and be prepared for that as we prepare for subsequent pregnancies. It's really important to note that mental health support and mental health issues such as depression and anxiety are very common in women with PCOS, and having the support from social workers, counselors, therapists, and care providers is very important as a woman embarks on fertility treatment, fertility diagnosis, and therapy. Longitudinal risk also includes issues with liver function, and women are at risk for non-alcoholic fatty liver and sleep-disordered breathing. Sometimes these risks only present when the body weight or body mass index is over a certain range, and we'll look at that in a moment. And sometimes they present at slightly lower than expected BMIs. And there's a lot of ongoing research to understand when and how that risk presents for women with PCOS to best be able to understand how to prevent it. Shown here is a BMI chart that I typically review with my patients, and we go through and mark where she falls on this grid, and sometimes male partners are very interested to know where they fall. This is a very cursory look at a body mass index. It does not take into account muscle mass or any other refined body composition measures. And the green is the range for a healthy body mass index, which is thought to be approximately 19 to 24. The blue range is underweight. The underweight range can also influence ovulation disorders and irregular periods. So it's very important to understand where and what factors contribute to your particular ovulation disorder. The yellow range is the overweight range. The orange range is the obese range. And it only goes to a certain number. Sometimes patients are outside the range that I present here, and we use calculators to understand what that number is. Any reduction in BMI from the red, orange, or yellow zone into the green is very beneficial and helpful for both fertility and pregnancy risk. Of course, the major question many of my patients have is, what are the risks for me as a woman affected with PCOS during pregnancy, and what can I do to reduce them? Sometimes the risks are modifiable by dietary, exercise, and lifestyle interventions, and they don't always need to converge on a lower body mass index. Those risks include typically risks associated with obesity or high BMI, and those are preeclampsia and placental disorders, preterm birth, and low gestational weights. It is not that every woman with PCOS will suffer from these gestational risks, but it is important to be aware of those risks and talk to your physician about how severe those risks might be in your particular case. So in summary, we have discussed briefly what are the diagnostic criteria for polycystic ovary syndrome, the importance of understanding the function of the entire reproductive endocrine axis, and what the risks are for women with PCOS before pregnancy, during the fertility and conception window, and in pregnancy and future health. At this point, I'd like to turn to the Q&A and take any questions that you have. Thank you so much for your attention. Okay, we have our first question. Did you discuss medications I can take to help this problem if I have it? That's an excellent question. And the answer to this question really depends on your goals. If right now your concerns are menstrual regulation, that would be a very different treatment than if your concerns are fertility. And so the plethora of potential medication options that are available do need to be tailored to you in your specific scenario. For women who aren't interested in intense hormonal regulation, there are very low dose options such as a progesterone only intermittent withdrawal to keep the uterine lining healthy. I have another important question that is asked very frequently. Is there any specific diet that I recommend for PCOS? So this is a key question, and there's a lot of information online about diets that either restrict a specific category of food, such as low carb, gluten-free, FODMAP diets for irritable bowel syndrome. And there's a variety of different diets that have been popularized by different people. I think it's a very individual discussion. I do generally think that carb balancing, trying to have meals that are very balanced, not to have unopposed carbs. And I know how easy it is during sheltering place to kind of bake cookies or cakes and have a lot, but just to think to balance those, particularly with leafy green vegetables and appropriate proteins. And if you're not allergic, including nut-based proteins. There's a lot of work on a supplement called myo-inositol in a ratio with D-chiroinositol. I partner with nutritionists and naturopaths to facilitate appropriate counseling around supplements in women with PCOS, depending what life stage they are and what their goals are for treatment. In terms of racial, there's another question, are there any racial differences in PCOS patients that affect fertility? This is a really important question, and there's not a lot of research that I can draw from. The basic infertility literature suggests that some outcomes may be slightly reduced for women of race ethnicities such as Asian or Black. We don't know why that is. It is really uncertain. And then for polycystic ovary syndrome as a subset of all women coming in for IVF, I don't have a great amount of information. What I can say is that regardless of what race ethnicity you have, to share your symptoms with your treating physician, whether they may be a severe acne, excess facial or body hair, or particularly androgenic alopecia in some race ethnicities, such as Asian and Black, can alert to this kind of issue. Okay, I have another question. If my religion does not allow IVF, will ovarian drilling either be an option for me or perhaps help me respond to the oral medications better? I think that in general, at a very distant level from understanding everything in your health history, I think that it is an option to consider. As I mentioned, it's not regularly performed, but it has some efficacy for certain groups and individuals, and it might be a therapy that would benefit you given your religion. Another excellent question. If my mother had PCOS, does it mean I will? And what about my children? So this gets at risk factors for PCOS, which I didn't talk much about at all. Family history is a key factor in understanding risk of PCOS. Historically, it was very hard to know whether mothers had PCOS, as the disorder was not well characterized, and diagnostic criteria were not well applied historically. Some of my patients go back and ask their mothers if they had issues with conception or irregular periods and excess facial body hair. And sometimes they find out that not only their mothers, but aunts and potentially even sisters had this issue. In men, a follow-up question is there a phenotype, or is there something that is similar to men? And taking the ovarian component out of it, it seems that in the early studies that are being published now, boys or men born to women who have PCOS, mothers with PCOS, there's a slightly increased risk of metabolic syndrome and metabolic phenotypes with increased abdominal girth, waist circumference. Here's a question. How do you feel about supplements as treatment? So I think it's really important to know what you're taking and why. I think that in some patients, a health optimization program, including light exercise, walking, stretching, and counseling from a nutritionist, which may include major dietary modifications or sustainable small dietary modifications, and may include supplements as part of that. And I think that when included as part of health optimization, I do think supplements can support and be considered as treatment. I think I would hesitate to say supplements alone are enough to provide endometrial protection or act as ovulation induction agents. But some women do notice return of ovulation, and these are anecdotes or patient stories where after using certain regimen of supplements, they might notice either easier weight loss or return of ovulation. I still would be wary as thinking them of nutritional supplements as a whole as treatment for the entire constellation of PCOS. So I hope that's been helpful as an answer to that. So do stay in touch with your physician in regards to your nutritional supplementation and your overall health. Part of that includes tracking your periods. It's so critical to know and understand whether those periods are regular, whether you have symptoms associated with ovulation, such as breast tenderness, moodiness, changes in your cervical mucus, and maybe other symptoms that are very specific to you. Are all PCOS patients overweight? Are skinny PCOS patients healthier? That's a really interesting question. I didn't delve into differences in phenotypes or how PCOS patients might look. It seems that there are slightly different categories of ovulation disorder, even within PCOS patients, those that are more at risk for gaining weight and keeping that weight on, and another group of women that seem to be either normal weight or slightly underweight. It seems that women who are slightly underweight to normal weight might not be as at risk for the obesity-related metabolic symptoms. It's a long conversation we have as we get better data to fully understand the risk. From what I've seen in my practice, these are two very different manifestations of PCOS, where in what you call skinny women, or women who are at the lower end of the BMI range in the normal to underweight, seem to not have those same risks. Okay, here's another question. If I have PCOS, will this affect my ability to have children if I want to have more than one child? Will I need IVF for each? Very interesting question. You may not need any fertility support for any of your children, and I do hope that is the case for you. But if you are under 35 and have very rare absent periods, you should present to your primary care or gynecologist to discuss your symptoms and understand whether it makes sense to be referred to a reproductive endocrinologist for further testing as you prepare for your family. If you've attempted conception for 6 months and you're over 35, you should come in to be evaluated to see whether or not and what the problems are so we can support your fertility. I wish I had a clear-cut answer, but there's such a range in presentation of women with PCOS that it's not a one solution fits all. Does PCOS increase the likelihood of a miscarriage? There's a lot of studies using a lot of variety of data sets that seem to suggest that there's a slightly increased risk of miscarriage among women with PCOS. I always recommend that women who are attempting conception take prenatal vitamins, particularly taking note of folic acid supplementation. I do discuss this risk in my clinic, but I don't think that we have enough data to say that it is exceedingly much higher than the rest of the population. A couple more questions. I have PCOS and am going through IVF. Am I more at risk for ovarian hyperstimulation, and what can I do to keep me safe? That's an excellent question. It's a question that I hope you've had some discussion with your care team. The factors that go into understanding a person's risk of ovarian hyperstimulation include something called an antral follicle count, or a count of those antral follicles or arrested cysts at the beginning of your IVF cycle. Many care providers also check a hormone called anti-Mullerian hormone to both understand reserve and severity of disease and gauge risk of ovarian hyperstimulation. That's one way to get a sense before your cycle even starts. Age is another major factor in understanding that risk. As you move through your cycle and come in for monitoring, the number of follicles that are apparent as well as your estrogen levels are helpful in understanding your risk. Some of the best ways to prevent ovarian hyperstimulation is to know how well you've responded and whether you're at risk in the cycle. And different practices have different thresholds, but there is an estradiol threshold and an follicle count threshold. And if you cross those, it may be worthwhile to talk to your team and your care provider about reducing your risk with freezing of your oocytes or embryos, or other measures such as altering your trigger. The trigger, as you know, matures your eggs before you come in for retrieval, and depending on what kind of cycle you are, there might be ways to reduce your risk by choosing the right trigger medication. There are supportive therapies after egg retrieval as well that are still under debate, and those include cabergoline, which suppresses prolactin production, as well as some of the pathophysiology involved with ovarian hyperstimulation syndrome. And it might be something that you additionally discuss with your team. Okay. Should I get my male hormone levels checked frequently if I have polycystic? Also another great question. I typically check once to facilitate diagnosis. I typically don't tend to follow levels unless there is a change in clinical symptoms. If there's a rapid onset, a rapid change, an increase, or if there have been a lot of interventions and there might be a major physiologic change that we see, and typically that's after a notable time period like a year. So I typically do not follow or check androgen levels unless there's a clinical suspicion that something else is going on. Does the increased male hormones increase my libido? It's unclear. It is possible. Everyone experiences their hormones differently. Some people have no change in their libido whatsoever, and others do. And so I think that it can, and sometimes that's a disturbing experience, and sometimes it's a welcome one. So depending on how you're experiencing it, and if it's a problem to you, you should definitely discuss that with your provider. Will taking out my ovaries make my PCO go away, especially when I am done having children? That's a very interesting question. Removing the ovaries will remove the hormones associated with PCOS, but it's a longer conversation because having ovarian hormones like estrogen is actually protective for many things, such as bone health, cardiovascular health, and it might be slightly more protective than the issues involved in untreated polycystic ovary syndrome. So I don't recommend bilateral ovary removal for treatment of PCOS when you're done with childbearing, unless there's multiple issues that complicate the clinical picture. Will PCOS affect the quality of my eggs? There's a lot of research on understanding egg quality in women with PCOS. One of the important things to note as well, some of that data suggests that in some women, egg quality is reduced. Every cycle is different. And when you're undergoing a, whether it's an IVF cycle or attempting spontaneous conception through boosting natural fertility or taking ovulation induction pills, every cohort or every group of eggs that are recruited in that cycle, whether it be for IVF or conception in any other way, has a kind of quality level, and there's a variability in cycle related egg quality. In some cycles, the entire cohort is phenomenal, leading to excellent fertilization rates and may even translate into excellent implantation and ongoing pregnancy rates. And sometimes an entire cohort might have poor egg quality. And so I am hesitant to attribute variability in egg quality only to the PCOS factor, and to note that there is very natural variation whether you do or don't have PCOS. But it does seem like there may be slight diminished quality in some women with PCOS. With that, I believe I've answered all the questions in the Q&A. I really appreciate your interest, your questions, and your time and energy thinking about this topic. I would like to invite you to visit our website at the MGH Fertility Center if you ever want to revisit information or look at the references for some of the studies that I've discussed, and know that we are available to support you as you contemplate what are the best treatment options for you in the setting of polycystic ovary syndrome. Thank you so much. Okay, with that, I'll end our webinar tonight. I hope you have a great evening.